Good afternoon. My name is Braden Kralt, and today I'd like to discuss stakeholder perspectives on a London model to prevent discharge to homelessness. I am a medical student in the Fort Chuck Research Group, and today I'm happy to present some findings on an intervention designed to reduce discharge into homelessness. Homelessness is a growing concern in Canada. Individuals who are experiencing homelessness have more frequent hospitalizations and worse health outcomes relative to housed individuals. When we think of discharge from the hospital into homelessness, particularly from psych wards, it isn't difficult to recognize that those discharged into homelessness often face environments that are inconducive to their recovery, and this leads to frequent readmission rates. Appropriately, this has been referred to as a revolving door of hospital to homelessness. And this revolving door cycle is expensive to the healthcare system. The research I'll be discussing today studies an intervention designed to break that cycle of hospital to homelessness. So how does the program work? Briefly, patients who are at risk of being discharged into homelessness are identified while in the hospital and referred to the research program by a social worker. Then these patients are connected with a coordinated access to housing services who arrange an intake meeting with the patients and provide homeless prevention supports as soon as possible. Finally, eligible patients who are paper ready and have IDs are added to housing priority lists and matched to find housing, housing allowances, and community supports based on their eligibility. This is a collaborative intervention, and access to housing and community supports would not be possible without the help of our community partners, such as the Salvation Army, the Canadian Mental Health Association, London and Middlesex Children's Aid Society, Youth Opportunities Unlimited, and Western Area Youth Services. As part of this research, we also conduct focus groups with stakeholders to assess what the program does exceptionally well as to find ways in which this program could be improved. So far, based on 3 focus groups, identified strengths fall into 3 main categories. Firstly, this program allows for improved communication between agencies to ultimately provide improved care for clients. Secondly, this program engages with community partners using all services that are available. With this, stakeholders identified that a key strength is collaboration between many different agencies with diverse experiences to provide plenty of resources to affected clients. Stakeholders have also praised the coordination of the program. For example, having a single first point of contact to network between participating agencies to streamline access to housing. Now, one of the main reasons we do conduct these focus groups are to identify where the intervention can be improved, and then we strive to make those changes. So when we asked our focus group participants, what are things that could be done better? Again, some common themes emerged. Firstly, stakeholders noted that clients can be referred to housing only when housing is available, and then they recommended establishing positive relationships with supportive landlords to increase access to housing for these individuals. For some landlords, there's a perception of extra risk when taking on one of our clients as a tenant, and positive relationships with landlords would help abate this concern. One other limitation that stakeholders had mentioned relates to improving access to government IDs by collaboration with local community partners. Currently, individuals must have IDs to access the intervention, so streamlining access to identifications would allow quicker access to housing and therefore less time spent in hospital. Lastly, the COVID-19 pandemic has necessitated that intake meetings with coordinated access be conducted virtually. It was recommended by several stakeholders that being physically present is crucial for fostering trusting relationships with clients. As vaccination rates continue to rise, we hope that in the near future we can proceed with this intervention more in person with on-site staff in the hospital. Despite some limitations, which we hope to address as we continue this research project, this intervention has been an enormous success. I'd like to end today's presentation with 2 quotes from our focus groups, which I feel are a great summary of the value of this program. What's gone well is actually the amount of people that have been supported into housing through our diversion and prevention efforts. And lastly, homelessness is a crisis, but is further exacerbated when it's in a medical setting. I'm very happy that these supports are available to Londoners. With that, I'd like to thank you for your attention, and I'm happy to address any questions you may have. Thank you.